Okay. Assalamu alaikum. Bismillah ar-Rahman ar-Rahim. Just to introduce the group, this is the thank you, Dr. Asma, for setting this up. We have other groups joining us. We have the fellows, Dr. Razan, I can see you. We also have a group of doctors. These are the Higher Medical Specialization Board in Nephrology at the University of Khartoum also. The time difference is not that big, should be about an hour, but they also have a couple from Canada, from Western Ontario and Calgary. But we go ahead and start, and this is a long talk today. And I actually consulted with Dr. Asma and the group whether they want me to give it as one talk or divide it into two. So my talk will be, last week we talked about AKI, acute kidney injury. This week we're going to cover chronic kidney injury, or what we call chronic kidney disease, or CKD. And then this is about 45, 50 slides just to cover everything about CKD. And then there is another talk, I just connected it to this one. It's about renal replacement therapy, which is closely associated with this. It's just the end stage of chronic kidney disease. So the other talk also is about 45, 50 slides. So we're talking about 90, 95 slides maybe. I'm going to try to pace myself to cover it. The main objectives is I'm going to be talking about CKD prevalence, the definitions that we have from KDOKI and KDIGO. I'm going to talk about the staging system, the natural progression, the symptoms associated with these stages, the most common causes. Why do we care about it? The implications to our practice, and when do you refer patients to nephrology? And then the complications associated with it, and management of all forms of renal replacement therapy. So I mentioned these words. If you can see here, this slide is very common and probably saw it a lot in the past. It's the iceberg, the tip of the iceberg here we call it, and this tip of the iceberg is the end stage kidney disease. That's patient on dialysis or patients who has received the kidney transplant. And then the vast majority of the patients is actually underwater. They're walking around, they're in a hospital, they're everywhere. Some of them actually, a high majority of them, they're not even aware of it. They're in the community, they're not even aware they have kidney disease, and they just got discovered accidentally. So this is the tip, which is the end-stage kidney disease, or ESRD. I mentioned last week that the terminology keeps changing. Very important we keep up with the change. So the word they're using most commonly now since last year is ESKD rather than ESRD. The word renal is disappearing. They're talking about the kidney itself directly. And sometimes we use the term CKD5. That's end stage, same thing as ESRD, ESKD. But then we put a slash after the 5 and write a D for dialysis or a T for transplant. So just so we're all talking about the same thing and we are aware of what all these things mean. Well, so how big a problem is this? Huge problem. This is the US data, the US prevalence, the global prevalence, and the Kingdom of Saudi Arabia prevalence. These numbers here about the US, I'm talking 2020 actually. So of all the US population, which is around 350 million now, I think, 15% of these people, that's 37 million people, have CKD. And in older Americans over the age of 70, the prevalence is actually 45%, which means half the people in America over the age of 70 have chronic kidney disease. The global prevalence, let me just go back to here to the US, it's really a big problem. Other statistics, these are real data, statistical data, says that 1 in every 7 Americans have chronic kidney disease. And that comes down to 15% of the population, total of 37 million. Now, out of these people, 9 out of 10 of them, they don't even know they have chronic kidney disease. As I just said, 90% of these people, 37 million, don't even know they have chronic kidney disease. And actually, 2 in every 5 of these patients have severe kidney disease and they don't know it. They don't know that this is the case. So let me tell you about the future, because you are the future. The data in 2010 showed that 13% of the American population have chronic kidney disease. In 2020, it's 15%, as I'm showing here. In 2030, this is going to be 17%. So just to show you what's a projection, or statistical projection of this problem. The global prevalence is similar to the prevalence in Saudi Arabia, about 10%, a little higher globally, 10.5%. And the global death, the death that's related to chronic kidney disease, is 4%. These are the different stages. I'm going to talk about that in details. So this is the prevalence divided into the 5 stages of CKD. It is a weapon of mass destruction, you know, really. I mean, the numbers I just showed you are mind-boggling. They are scary. I think really more than anything else you can think of. So what's the definition? That's the National Kidney Foundation KDOQI guidelines. I think everybody now is aware of KDOQI. Kidney Disease Outcome Quality Initiative. What is that? That's really writing all the books now, all the guidelines for clinical practice as far as kidney disease is concerned. And this actually started back in 1995. And now we have KDOQI guidelines for everything. AKI have KDOQI, CKD have KDOQI, dialysis, KDOQI, transplant, KDOQI, hypertension, diabetes, you name it. We have KDOQI guidelines. These guidelines are very helpful. They're extremely helpful. They guide our practice. They are guidelines. They are guiding our practice, the day-to-day practice. And then there's the KDIGO guidelines, Kidney Disease Initiative Global Outcome. This is globally. What do? They collect studies and data from the globe, from all over the world, and they implement them into guidelines. So these are the international guidelines. These are the US guidelines, okay? So it is kidney damage. In its simplest form, it's kidney damage or decreased kidney function for 3 months or more. I want you to remember last week, though, I said AKI stops at 3 months. And this 3 months really distinguishes, it's a cutoff between AKI and CKD. So this is just the juice, the terminology. I mean, this is just how we define CKD. Okay, why 3 months? Because the first word in this disease is chronic. It is chronic kidney disease. And when we say chronic, we talk about more than 3 months. So it's kidney damage, pathological abnormality, okay, based on biopsy. If somebody get a kidney biopsy and they have scarring and they have a scar tissue and they have inflammation, they have anything there, that's biopsy data, abnormality, pathological abnormality. Even imaging, an ultrasound showing, you know, a cyst or 2 or 3, that's chronic kidney disease. Even if you have normal function and even if you have normal biopsy, okay? And markers. And Dr. Mamoun, I remember last week, I hope he's with us. By the way, I invited two of the eminent consultants we have with us in the Department of Nephrology here, Dr. Mamoun, Sid Ahmed, and Dr. Hafiz, Abdul Hafiz Fadl, for any interjection or any addition they want to add. So you talk about markers. We are very bad in nephrology in markers. The only markers we have is albuminuria and creatinine, serum creatinine. So these are the markers. So what I want to say, any of these abnormalities will go into the definition of CKD. Decreased function is decreased function. low GFR, but it has to be in a steady state. You know, it can't go down and then recover completely. That's not chronicity. So it has to be in a steady state. Multiple readings over several days or weeks, and you establish CKD based on that. These are highly objective criteria. Both KDOQI and KDIGO use this criteria to define chronic kidney disease. The transplant kidney, how about the transplant kidney? The transplant patients are CKD patients. All transplant patients, even transplant patients with normal kidney function. This morning, I did my transplant clinic. I saw about 15 patients. These are older transplants, like more than 4, 5, 6 years old. And it's amazing. All of them have perfectly normal creatinines, 80s and 70s and 90s, but they are classified as CKD patients. In fact, they are ESRD patients who has excellent kidney replacement therapy, which is transplantation. So it's very important that people understand that, both patients and their families and doctors understand that is when you replace the kidney function with a transplant kidney, that patient will still have chronic kidney disease, even if his kidney function is normal and he doesn't have proteinuria or doesn't have anything, but he's on kidney replacement therapy. So even if there is no damage in this transplant kidney, even there's no scarring, there's no rejection, imaging is normal, ultrasound looks normal, there's no markers abnormalities like proteinuria or albuminuria, and their creatinine is perfectly normal. This kidney transplant is just merely a form of kidney replacement therapy for a failed native kidney. Symptoms. It's really asymptomatic. That's why it's silent. It's a silent killer, totally asymptomatic until you reach the advanced stage. The symptoms usually occur in the late stages. And these symptoms are related to anemia, bone disease, GI symptoms, cognitive impairment, impaired physical function, infection, and cardiovascular disease, of course. How do we assess kidney function? GFR is the best index of kidney function we have right now. All guidelines use GFR, not serum creatinine. I talked about the limitations of serum creatinine. You know, things that give you high serum creatinine, but your kidneys are perfectly normal. I talked about that last week. And since 2013 in the US, the machines in the lab that when you order a renal panel, a kidney function test, a simple blood test, 90% of the labs in the United States, definitely in the area I practiced in Ohio, all the labs in Ohio actually, but 90% of all the labs in all of the US, you order a renal panel, you know, just a BUN, creatinine, chloride, blah, blah, blah. They actually give you eGFR. The machines in the lab automatically calculate the eGFR. They were, when I was practicing there, they were still using the MDRD equation GFR, but the MDRD equation GFR has a lot of limitations. And now most people use the CKD epi equation to calculate it. And I will explain that a little bit in this same slide. So here we don't have that right now. When we order renal panel, we don't get an eGFR. There are certain settings in the computer of the machines. That's the measurement that can calculate it for you. Of course, it uses a creatinine. It uses the age of the patient, which is known to the lab people. You know, they have the MR number of the patient. They know the labs. In the US also, they tell the lab if the patient is white or black. You know, so of course, the lab knows if the patient is a male or a female. So these are the parts of the equations, MDRD or CKD epi, that actually calculate the eGFR. The widely accepted threshold defining a decreased function is less than 60%. This is the limitation of the MDRD equations. It is not good. It is not accurate at measuring accurately the kidney function at a higher level GFR. The CKD epidemiological study equation is much better in that regard. And kidney failure, of course, failure. I hate the word failure, but here it is definitely failure if the GFR is less than 15 ml per minute per 1.73 square meter. We have to confirm. Yeah.
Dr. Taib, just one quick question. As we know that the creatinine is 100% cleared by the kidney. There is no reabsorption. So why do not we depend on the estimated creatinine clearance rather than the estimated GFR? Aren't they the same, or is there a difference between them?
Well, a good question. Number one, I mentioned all the long list of limitations last week about the limitations of using the serum creatinine measuring. I mentioned the muscle mass of the patient. I mentioned the stage of hydration of the patient. I mentioned medication interfering with the excretion of the creatinine. You're right, there is no reabsorption of creatinine. You're absolutely right, but there is tubular secretions of creatinine. In the tubules, in the distal tubules, creatinine is actually secreted there. And in addition to filtration, it is filtered and it is secreted. So I mentioned all these factors that limit using the serum creatinine. Many factors, physiologic factors, physical factors regarding the patient, other medications, even in the lab. You remember I mentioned a group of antibiotics that actually interfere with the assay, the measurement in the lab of the serum creatinine. So that's why we use the GFR. The other reason is we want to be dealing, you're reading papers in China, you're reading studies in Sweden or in Canada. We all want to be talking about the same thing. So this is called standardization. We all have to be talking about the same thing. Okay, so confirm chronicity is very important. You're calling it chronic kidney disease. You better make sure it is chronic. So the first step is really to confirm chronicity. You need to document damage or decreased function for more than 3 months. I know that's difficult sometimes. It has to be more than 3 months. Well, I can't say anything other than the kidney function is impaired for more than 3 months. And to do that, again, I mentioned this last week, you need to review past eGFR or past kidney function. And you need to get some information from somewhere, patient coming to you from another hospital. You need to go back and see in that hospital or talk to other doctor. Communication is extremely important. Talk to his doctors in that hospital or to your co-doctor here in this hospital. Hey, did this patient have normal GFR or 3 months ago or not? Review past albuminuria too. They might have normal GFR, normal creatinine, but they may have albuminuria, proteinuria for more than 3 months. That make it chronic. Review past urine analysis if you have. All these things will help us establish chronicity. We have to confirm chronicity. We have to review past imaging, look for the size of these kidneys 3 months ago. Okay, cortical thickness, very important. The thickness of the cortex is 1 centimeter. If it's less than 1 centimeter, that's cortical thinning. Cortical thinning goes with chronic kidney disease. Of course, cysts, if the patient has multiple cysts, that will help you establish chronicity. Okay, now there's a very good question somebody might ask me. I don't have any of that. I don't have any documentation. I don't have any, but I tried my best. I tried to get baseline lab, baseline creatinine. I couldn't. Patient is, whatever, coming from out of the country. I don't know what was going on for him in Bangladesh or in Sudan or wherever. Okay, then in that case, I'm telling you, the only way you can document that this is chronic is you take this point you're in right now, this point in time you're in, and you establish what you have now, and then 3 months from now, you repeat the labs and make sure you're getting the same numbers you got now. Is this clear? This is not me, by the way. This is KDOKI recommendation guidelines here. Is this point clear? I really want to make sure people, I wouldn't call anybody chronic kidney disease if I can't establish chronicity. Sometimes I can't establish chronicity. I tried, I couldn't, no previous lab, nothing. So you take this point in time right now, and then 3 months from now, check the kidney function again, and see if it's still the same level that you found 3 months earlier. That's chronic. How do we stage it? And why do we stage it? It's very important we stage it into 5 stages. This is not just for fun. This is very important, the staging. It guides our management. We stratify, we risk stratify them for progression and complications. We just get ready for them to decline if they are at a certain stage. And there are certain complications. I will show that in a few slides from now. There are certain complications that appear at certain stages. How frequently do you see them in the clinic? The intensity of the monitoring. I know in the clinic we tell you, okay, come back in 3 months, come back in 2 months. No, you come back in 2 weeks. Why? Because that's also based on the stages, by the way. The stages actually tell us when do we bring the patient back to the clinic for visits. So the intensity of monitoring is also determined by the stage. Patient awareness, no, my slide is not moving. And then you have to make the patient aware. Really, patient awareness and education. You tell the patient, it's not difficult. Explain to them, hey, you have this stage, you have this stage, you have that. These are the stages. We call them the G stages. By the way, G is for GFR, the word G. So we have G1, G2, G3A, G3B. So G3 divided into A and B, G4 and G5. These are the GFR. These are G1 GFR is when your GFR is greater than 90 ml per minute per 1.73 square meter. This is G1, meaning it could be 100%. It could be 100 ml per minute, okay? But you have albuminuria, you have proteinuria, you have 2 cysts here and 3 cysts there, you have this, you have some blood in the urine. All of this is considered, would put the patient in CKD stage 1 or G1. So kidney function, GFR, perfectly normal. But the patient is classified as CKD1. CKD2 or G2 is when the GFR is 60 to 90. G3 or CKD3 is when the kidney function is 30 to 60 or 59. And then that's subdivided into G3A here, kidney function between 45, 59, and G3B. That's a GFR of 30 to 44. Very important. This dividing stage 3 into A and B is extremely important. But by the way, I will show you when you should be sending the patient to the nephrologist. It's right here, right here. This is when the patient should go see a nephrologist in a nephrology clinic. If you're not a nephrology fellow yourself, we'd like to have you all as fellows with us here in our department, of course. I'm trying to market the nephrology here. G4, GFR 15 to 29. Okay, you see that? That's G4. That's CKD stage 4. GFR is 15 to 29. And then, of course, G5 or ESRD or ESKD, that's less than 15 ml per minute. As I said earlier, the G3 or CKD3 is broken up to reflect more accurately low GFR relation with poor outcome. Again, if you want to be more specific, as I said in one of my first slides, you can say CKD5D. That means the patient is CKD5, that's ESRD, ESKD, and D here is for dialysis, on dialysis, okay? So CKD5D is end-stage renal disease and the patient is on dialysis. And then you have CKD5T. Do this for me. I'm a transplant nephrologist, please. People don't use that. So T, when you tell me this patient is CKD5T, that's the patient who has end-stage renal disease and his kidney function was replaced by transplantation. All these things I'm saying here, all this slide is from KDOQI and KDIGO guideline. Albuminuria, also now we have different stages of albuminuria, by the way. I remember the days when I was a fellow, when we used to call it, oh, this patient has microalbuminuria. What is microalbuminuria? When the albumin in the urine is 30 to 300 milligram per gram of creatine. 30 to 300, we used to call it microalbuminuria. Nobody used these terms anymore, don't use them. And then there is a macroalbuminuria. These terms, macroalbuminuria used to mean when the albumin in the urine is more than 300 milligram of albumin per gram of creatinine, okay? These are not usable anymore. Nobody uses that. So now albuminuria is accurately divided into A1, A2, A3. ACR refers to, we measure albumin creatinine ratio. We call it ACR, albumin creatinine ratio. Like here in this case, the A1 is when the albumin in the urine is less than 3 milligram albumin per 1 gram of creatinine. So that's A1. And then you have A2, albumin creatinine ratio between 30 and 299 milligram albumin per gram creatinine. That's A2, okay? That's the same range when we used to call it microalbuminuria, okay? And of course, A3, albumin creatinine ratio more than 300 milligram of albumin per gram of creatinine, okay? So please don't use microalbuminuria or macroalbuminuria. We have a better classification system here to the degree of proteinuria. What is this? So, you know, you want to talk to me, you want to consult with me about a patient you have in the floor, you know, we want nephrology consult. Okay, this patient has G3B A2 CKD. That tells the whole story. You're telling me a lot by these words and numbers. You know, this patient has G3B. From that, I understand the GFR is 30 to 45 ml per minute per 1.73 square meter. A2, he has albuminuria between 30 and 299 milligram per gram. You're giving me the full picture. You're giving me all the information that I need to stage the patient. So staging is extremely important. The staging is not just, it's really help with the management, the prediction, the prognosis, the management, everything. So the stages, stage 1 is chronic kidney damage with normal or increased GFR. Could be increased, by the way. There's something called hyperfiltration. You could have a GFR 120 or 130 ml per minute. That's too high. That's damage, actually. Okay, if you can document proteinuria with it, or an early stage on a biopsy of the kidney showing minimal change disease. Early diabetic nephropathy, by the way, is hyperfiltration, and actually hyperfiltration injury to the kidney that leads to the progression of chronic kidney disease. Stage 2, kidney damage with mild. In the past, we used to use words like mild, moderate, severe. That's running out of favor. We don't use that anymore. You know, we just talk about these numbers. And that's the standardization I want to talk about. This is just a copy of the chart from the KDIGO in 2013. It has the same thing I just talked about, the G stages and all the stuff that I just, including the proteinuria, the staging. So what's implication of CKD to our clinical practice? CKD patient has very high rate of end-stage kidney disease, very high rate of going into ESRD, of course, but also very high rate of cardiovascular disease and death. Prevention and early detection is extremely important. And we also need to provide the people who make the decision maker, the policy, the public policy and planner for healthcare about this problem. It's a common major public health problem. Internist, if some of you want to stay as internist, has a major role to play here. CKD is underdiagnosed and undertreated. It's a high risk factor for cardiovascular disease. If you ask any cardiologist now, they are convinced and they will tell you CKD is CAD equivalent. What does that mean? If the patient has CKD, it's just like he had coronary artery disease confirmed by cardiac catheterization, or had a stent, or had an MI proven, confirmed. So the patient that you see with CKD, in terms of cardiovascular risk, is just like that patient who had a heart attack, literally, even though they didn't have a heart attack, but the risk is considered as high as actually having CAD, chronic coronary artery disease. Early detection is extremely important, not only to slow the progression to end stage, but to prevent morbidity and mortality from cardiovascular disease. I want to draw your attention here to the word slow. I didn't say stop. You can't stop it. It's a train. It's slowing. And we have to be very honest with ourselves and with our patients. There is no way we're going to stop this There is no way we're going to cure it. We don't have a cure. We don't have a bullet, a silver bullet to stop it. There's no way. We can slow it. So the word slow is very important here. It's not just semantics. It's not just playing with words. When do you refer to the nephrologist? It depends on the practice pattern and healthcare system and geographic location in the country. Different countries have different policies about this because, of course, other factors come into play here. In the US, it's stage 3. That's decided by Medicare, by health insurance, in the insurance industry, the hospital systems, you know, the vast majority of the hospital in the US are private hospitals, and the insurance system there is very, very powerful. And of course, there's something called Medicare, and that's the government provided healthcare for the sectors in the community who can't afford to buy commercial health insurance. Refer all symptomatic patients. If you are questioning the cause, if you're not sure of the cause, and most of the time we're not, even us, the nephrologists, we are not. Most of our, even patient with transplant, we really don't know, but they are end stage. We know that for sure. If you are questioning a cause or an ongoing cause, refer to the nephrologist. If the patient has heavy nephrotic proteinuria, please send them to the nephrologist. If it's difficult to manage complications like resistant hypertension or anemia, you tried your best, anemia is persistent, or bone mineral disorder is persistent, refer them to the nephrologist. Rapidly progressing patients, of course, the rate of progression. In my experience, and I don't know where I got this from, but I think there are some data and studies if we dig deep. For example, diabetic nephropathy, the most common type of chronic kidney disease. This is just from my practice. I would be very happy if somebody loses 5% of their GFR per year. You know, Dr. Sultan has a lot of experience with this diabetic kidney disease, and you know, in some patients, you might be able to, you know, lose 2.5%. You know, that's actually success. That's very, very good if you can. If the patient is losing 2.5% per year, but most other chronic CKD patients, I think losing 5% per year is good, actually, is a success. So the point I want to make here is really, you know, this is no stopping. You can't stop this disease at all. At all. I mean, AKI, I talked about AKI last week. You can reverse it completely, even at 3 months, and the patient can have normal kidney function after that. Causes, the same all over the world. This has not changed in my career time, 20 plus years or 25 years. These are the causes. This is the y-axis here, the incidence per million population. And here is the years since 1980. Until actually now, you can go up that to 2020, 2022 or 2020. This is the same causes. Diabetes number 1, hypertension, then GN, then the cystic disease and the hereditary disease. Okay. Okay. So these are the causes. This is just a pie chart to display the causes again. Diabetes 50%, especially in the kingdom. This is actually, they did several studies here, and this is exactly what they see. You know, 50% diabetes, 25% hypertension, and then the GNs and the others. But these are the major causes. This is a primary diagnosis in patient who actually is starting dialysis. This is data from the kingdom here. Okay, I just want to compare the heart and the kidney. You know, my friend, Dr. Fadl here, is very interested in the interaction or the crosstalk between the heart and the kidney. The kidney talks to the heart talks to the kidney. If the heart is bad, the kidney goes bad. If the kidney is bad, the heart will definitely go back. Look at the stages. So I have CKD here on the right side of my screen, CKD, and I have CVD, cardiovascular disease here. So at risk, you have albuminuria, proteinuria, you're elderly, and elderly diabetic hypertension. Here, CAD, left ventricular hypertrophy, goes together with albuminuria, elderly patient, diabetic hypertension. So even the stages of these two diseases go hand in hand. Then here you go, GFR drops, CRI. CRI stands for chronic renal insufficiency, a term which we don't use anymore. This is just an older slide here. But chronic kidney disease, or CRI, then it is equivalent to the establishment of atherosclerotic cardiovascular disease. Then you have the progression from this point on until the patient reaches ESRD or ESKD. And then the end stage, of course, is ischemic cardiomyopathy here. So this is just to show you how they go hand in hand together until the end of the road. Cardiovascular events, here on the x-axis, I'm showing you the GFR declining from around 60% to 15%, and look at the cardiovascular event going up and up and up as the GFR is declining. Very compelling, very convincing evidence of cardiovascular events and GFR. Same thing. This is just another data. Events, cardiovascular events going hand in hand with the decline in the GFR. In the general population, cardiovascular disease, that is, cardiovascular is in general population about 5 to 12%, but in our dialysis population is 40%. That's 4 out of every 10 dialysis patients have cardiovascular disease, whether it's overt or covert. Okay, this includes left ventricular hypertrophy, CHF, coronary artery, you name it, but they have it 4 out of 10 dialysis patients. Okay, that's why when we do kidney transplant for this dialysis patient, actually one of the things I'm very proud of I established in this center is I convinced one of the brilliant cardiologists, Dr. Khairullah, to be part of our transplant team. So all our dialysis patient has to be cleared by the cardiologist. He came and established a clinic with us in the pre-transplant clinic to clear all our patients. Just like we do, we check viruses and we check things, we get the cardiologist to see them, they do stress tests, they do an echocardiogram, very important. So yes, so dialysis patient, 40% risk of cardiovascular disease compared to 5 to 10%, 5 to 12% in the general population. The natural history, initial injury, for example, a strep GN or a reflux, then what happens in that injury, each kidney had 1 million nephrons. You know that from physiology and from anatomy. Each kidney had 1 million nephrons. So if you knock off 100,000 nephrons or 200,000 nephrons, you end up with 800,000 nephrons. Those 800,000 nephrons start to work as 1 million nephrons. They do the work of 1 million nephrons because they're adapted to that body and their needs, removing toxins, removing, so you're overworking the remaining nephron, and that's called adaptive hyperfiltration. To maintain the GFR, the goal is to maintain the GFR. So the remaining nephron that's not damaged, they are going to get damaged by overworking, hyperfiltration. It's an adaptive hyperfiltration. And this leads to long-term damage due to hyperfiltration injury. And of course, then progressive CKD is established, and then nephron drop off. Of those 800,000 each year or so, you get 50,000 drop, another 100,000 drop, and so on. So that really explains the natural history and the progression of CKD. Why does it go from stage 1 or stage 2 to stage 5 in 3 years or 2 years? That's the mechanism. That's why it happens. Slow the progression. I insist on the word slow. I want to make sure everybody use it. We use it among ourselves and we tell our patients, slowing, not stopping. So here you have the GFR on the y-axis, and here you have the ESRD. If you're lucky, and this is only in the acute situation, you achieve regression. This can only happen if the patient has CKD for less than 3 months, okay? So that's achieving regression. Regression means that you give the patient perfectly normal kidney function. That's only in the acute. It doesn't happen in CKD. Arrest the progression or arrest the progress. Arrest means to stop it. Good luck with that. It's not going to happen. You can't. No arrest. No, it's not. You're not going to stop the train. No way. Retard the progression. This is the reasonable goal that we aim at. Okay. Or the patient just very quickly drop to ESRD, for some reason or another. Usually these are patients who don't have regular follow-up with doctors. This is the KDOKI blood pressure guidelines for patients with CKD. Less than 130/80. This is really important. This is the goal blood pressure. If you have a patient with a blood pressure 140/90 and they have CKD stage 3, you're not doing a good job. You need to lower that blood pressure less than 130/80. And of course, you have to use an ACE or an ARB and add a diuretic and a beta blocker and a calcium channel, whatever it takes. Get it down to under 130/80. How do we slow the train? Achieve optimal blood pressure control, less than 130/80. Achieve optimal glycemic control. What do I mean? A1C, hemoglobin A1C, less than 7%. Achieve total blockade of the RAS system, increase the doses of the ACE or the ARB. There is no place for combining ACE and ARB together. It's very questionable that what we call the dual blockade of the renin-angiotensin-aldosterone system. Achieve, cardiologists now are really high on using aldosterone. And then of course, avoid further injury and damage, that's nephrotoxins. Here's the story. Here's how it progress. Specific treatments, the GFR is going down, control the blood pressure, establish the goal blood pressure and hemoglobin A1C in diabetic. Make sure you're using ACE inhibitor. Give them the specific treatments if you can. And here, when you get to stage 3, the patient needs erythropoietin therapy, calcium carbonate, treat the acidosis with sodium bicarbonate, correct vitamin D deficiency. When the patient gets here, 20 ml per minute, we would like to see them in a transplant clinic, okay? Because the transplant modality is a modality of choice. And then there are other modalities. Vascular access needs to be established here. And then of course, when you're down to 10, you're starting dialysis. The uremic syndrome, very important. We recognize these symptoms: anorexia, nausea, vomiting. Pericarditis is a medical emergency or a nephrologic emergency in these patients. And if it develops, you need to dialyze immediately. You don't even wait until tomorrow. Progressive uremic encephalopathy, neuropathy, seizures, volume overload, hyperkalemia, hypocalcemia, hyperphosphatemia, metabolic acidosis. These are the features of the main uremic syndrome as the patient is progressing. How do we manage? General management and treat any reversible causes. I talked last week about acute on chronic. There's something called acute on chronic. Patient with established chronic kidney disease, and they come in, you give them contrast like we discussed last week, and then the creatinine goes up. So you need to, or you give them any nephrotoxic medications, you need to treat any reversible causes. You need to get them back to their steady state or baseline or whatever you call it. Preventing or slowing progression, I don't think you can prevent it. Treat the complication, adjust the drug dosages based on their GFR, identify and prepare patient for treatment of end-stage renal disease. We have this clinic here. It's called the low GFR clinic. These are patients who are has a stage above G3A. So they go to this special clinic, and we do all these interventions in this clinic, including referring to transplantation. Identify CKD patient approaching ESRD. It's a co-management between internist and nephrologist in the early stages from G1 to G3A. This is a co-management team between the internist and the nephrologist. Prepare them for renal replacement therapy, counsel them regarding modalities, all options, treatment option plans, what we call the TOP program. This include the dialysis nurses, the social worker, the dietitians, and all of that ancillary staff, and counsel the family and make sure they understand what's going on. Mineral bone disorder, to correct hypocalcemia, give them vitamin D, give them binders to lower the phosphate. calcium therapy, excessive calcium therapy. Be aware of vascular calcification if you give too much calcium. If the PTH is resistant after you correct the hyperphosphatemia, then you need to give them what we call the calcimimetics, the cinacalcet. This is the major breakthrough in about 10 years ago in the treatment of hyperparathyroidism. Anemia, of course, it's due to the kidney is an endocrine organ. It produces erythropoietin, it produces vitamin D. All these are hormones. So they would have erythropoietin deficiency. The anemia is usually normochromic, normocytic. The half-life of the red blood cells is reduced significantly in these patients. Normally it's 120 days. It is very low in patients with advanced chronic kidney disease. Sexual function, reproductive function, more than 50% of patients are, and this is under recognized, more than 50% of patients in patient with a stage 3B to 5 have actually sexual and reproductive function, erectile dysfunction, decreased libido, disturbance in menstruation in female, very decreased fertility, amenorrhea. Most of them have that, and people don't talk about these things. There's nothing to be shy about. You can talk to the patient about that privately. Malnutrition is a very bad sign. It's very common in advanced CKD. Poor food intake due to poor appetite, metabolic acidosis, causing bone disease. The metabolic acidosis due to the failure of the kidney to excrete acid actually leaches the bones. It eats the bones and it causes bone disease. It's strongly associated with death, malnutrition on dialysis patient, one of the very poor prognostic indicator. Poor food intake, poor appetite, impaired digestion and absorption. It basically affects every part of the GI tract or the brain, the CNS, everywhere. Stage 5 end stage, this is the end of the road. But it's the beginning of a new journey, and that's called renal replacement therapy. And that's actually my next talk. Are we okay, Dr. Asma? I finished the CKD talk, and the next talk will be about ESRD, about renal replacement therapy. If you want me to proceed, we have enough time on this Zoom?
Yes, doctor, we have enough time.
Okay, we'll finish it then. So this is stage 5. It's the end of the road, but the beginning of a new journey, a new road. And that's the road of renal replacement therapy. You need to help and support me, doctor. I mean, I had some patients literally telling me that in tears, okay, what am I going to do? You have to help me. We have to help them and support them, okay? And some of them, they just ask you straight out, give me my options, and they are entitled to their options, and we are obligated to give them their options. We just can't tell them to, oh, you have kidney failure and I'm going home, to my family, and you deal with this. That's not appropriate. It's not ethical. And we have an obligation, ethical and professional and legal obligation to support them through renal replacement therapy. How do we replace the kidney? It's a major life event. We have to sympathize with the patient. We want to avoid crash landing, what they call crash landing in the emergency room. What do I mean by that? The patient that I'm sure you, all of you or most of you have seen those patients coming to the ER with a creatinine of 1,800 and a potassium of 7 point something and a bicarbonate of 8. Just showing up in the ER, and they just call you there, at 2 o'clock in the morning or 11 at night. This is called crash landing, and we want to avoid that. We really want to avoid that happening. That's why we need to follow them and see them and try to slow it and try to avoid this. It's costly. It's very costing to the system. It's bad care. I don't like to see that at all. We need to help them choose, not just, hey, there's dialysis and you decide and you go on dialysis. No, give them all the options, and you need to try to maintain their autonomy. Some people will be in denial and depression, and then they go into acceptance. So we couldn't treat the disease, right? We couldn't treat CKD. We couldn't cure it. We couldn't treat the disease. Let's try to treat the patient. And I always use this slide from Professor Sir William Osler. He's one of the doctors who founded Johns Hopkins University Hospital, and he's a father of clinical medicine as we're practicing it today. He's the first person who used the word round. Let's go round. So he said, a good physician treats the disease. That's a good physician. You know the disease, you treat it. I mean, we're not even good at treating CKD disease, right? We're not good. We didn't treat it. Our knowledge is still lacking. I mean, it's falling behind. But if we can't treat the disease, he said, a great physician treat the patient who has the disease. You see, I mean, this is really, I like this saying. This is what he said. So we need to inform the patient, explain things to them, educate them. We have to be patient with them and compassionate with them. Very important. At least if we can't help them, reach ESRD, we can do something now. What are the options? Transplantation, transplantation, transplantation. That's always the option. Anybody is a candidate, a potential candidate for kidney transplantation until proven otherwise. So always talk about transplantation, please, first, okay? Of course, we don't do emergency transplantation. There's no such thing as emergency, unless you get a cadaver kidney and the patient is prepared, a deceased donor kidney and the patient is prepared and ready and listed, and then we transplant. But transplantation is the first option. And then dialysis is the second option. I'm talking about options for replacing the kidneys when they reach end stage. Transplantation first, dialysis second, and then conservative management. And I will talk about that in details. It is an option. That's not to do transplant and not even to do dialysis, but conservative management. This is a transplantation, a straightforward surgery. The kidney is connected to the external iliac artery and external iliac vein, and the ureter of the kidney is connected to the bladder. Very simple, straightforward surgery. Okay, it's a treatment of choice. I think I may have shown you this slide. I'm going to be just talking about who's candidate. Everybody is a candidate until proven otherwise. Age is not a contraindication to transplantation. Age in itself, the chronological age. Why? Because survival is better. Simply, people live better with a transplant than staying on dialysis. The quality of life is better and the cost to the system is much less with transplantation. When we prefer this one, we like the preemptive transplantation. That's transplantation before they reach dialysis, before they get dialysis, even one dialysis treatment. We don't want to see it. There are different types, 7 types of transplants we do right now, starting with deceased donor, expanded criteria donor. These are marginal kidney. And then the best kidney you can get is an identical twin transplant if you have an identical twin. Again, we prefer preemptive before the need for transplantation. What's the price to pay for getting a transplant? Lifelong immunosuppression. Because if you don't do that, the risk of rejection is there. Very high risk of rejection if you don't use immunosuppression. Of course, this is associated with infection and with malignancy and a lot of medications. The average number of pills my patient this morning in the clinic are taking is about 10 to 12. That's the average number of medications. 3 immunosuppressive medications, a couple of antibiotics and antiviral, 3 blood pressure medicine, and of course the diabetic with their usual list of medication. We're trying to play with the play the game of not to give too little immunosuppression, because the patient can have rejection, but at the same time not to give too much, because then infection and malignancy occurs if we over immunosuppress them. So we're trying to play that game. This is just the number of transplants. I just want to tell you something. If you can see this slide here, in 1979, that first kidney transplant was done here in this hospital in 1979. This is the first kidney in the Middle East and in the kingdom. So the history is ours here. Then the dialysis options, you have peritoneal dialysis, and that's also divided into 3 types: intermittent, continuous, and cycling. I will show you this in further slides. Then we have hemodialysis, and that can be in center, like the huge center we have here in building 1, the first floor, almost 500-600 patients there dialyzing. And then we have people doing home hemodialysis now, quite a few patients. And then there is, of course, in the ICU setting, patients who need continuous renal replacement therapy, hemodialysis. We do continuous renal replacement therapy. That's hemodialysis. Also, peritoneal dialysis, 10 to 20% of renal transplant patients. It's interesting. This number is the same in the US and in Saudi Arabia. The number of all the patients with end stage who are doing peritoneal dialysis, about 10 to 20%. In Canada and England, actually the opposite. The vast majority of patients are doing peritoneal dialysis. Of course, that's related to the healthcare system in those countries. In our center here, we have 80 patients and the number is growing, very convenient, painless, very easy, very safe, very gentle, no vascular problem, no blood, no dialysis catheter. Patients and family control everything. And it's and it's daily, it's every day, okay? You do it daily, not like hemodialysis, you do it 2 or 3 times a week. This is what we use for peritoneal dialysis. It's called the tank-off dialysis, peritoneal dialysis catheter, and we put it in the abdomen here. This is the umbilicus, it just gets straight in there. And it has a balloon, a cuff in it, secure it in the peritoneal space. And we just put the fluid in, I'll show you. We put the fluid in like this, a bag of fluid goes in, sit there for a couple of hours, and then we put another bag down below and then it drains out. So this is intermittent PD or CAPD. Some people, yeah, CAPD does, continuous ambulatory peritoneal dialysis. This is just a view of the peritoneal space. It's huge. You have the parietal peritoneum and the visceral peritoneum and the space in between. All this blue space you see, that's what we use for dialysis. And this is the membrane, the peritoneal membrane itself here, the fluid. This is a dialysate we use, and this is the blood on the other side. The blood is actually in the capillaries on the peritoneal membrane. So the peritoneal membrane has a lot of blood supply, very rich blood supply, it has capillaries running in it. And this is it. This is the blood. And when I say the blood, this is what I mean here. And then this is a dialysate we put. And then across the membrane, between the blood and the space, the peritoneal space, the exchange happened. Is this clear? Very simple. The idea is really, really simple. How does it work? The peritoneal membrane allows transport. So it provides clearance, it provides removal of excess fluid. There are 3 distinct processes: the diffusion, the ultrafiltration, and the fluid absorption. This is what happens during peritoneal dialysis. I did some drawing here, but I'm not very good at drawing pictures. But infusion, you infuse the fluid, you dwell, meaning you let it sit inside in the peritoneal space, and then you drain. That's it. That's what peritoneal dialysis is. An exchange is defined as infusion, dwell, and drainage of the dialysate. Okay, they infuse the dialysate. This is a pre-made, ready solution. We have it in the pharmacy, and it can be infused by gravity, like I showed in that guy in the bed. It goes in there, sits there for 2 hours, and then it dwells, and then we drain it out. It comes out with all the toxins and all the excess fluid and everything else. It's the comfort of your home. You're sitting at home, you're watching TV, you're with your family. There's nothing like home. It's really very comfortable, very convenient. You're not sitting in a dialysis unit, people you don't know, and nurses and stuff. And so it's really convenient. Oh, this is important. This is the cycler. This is an automated dialysis, we call it automated dialysis, or CCPD, continuous cycling peritoneal dialysis. At bedtime, you can go to sleep, the patient can go to sleep. You see this lady here, hooking herself up here, went to sleep, and the machine is doing all of that for her until the morning. Excuse me. Until the morning, okay? So really convenient, very nice. The next best thing to transplantation is actually PD, okay? Of course, complication, infection, peritonitis. Every patient on PD is allowed 1 episode of peritonitis a year. That's the normal, no matter how careful or how clean you are. And then over time, when you do PD for 10 years or 20 years, you get ultrafiltration failure because the glucose in the solution we put in there causes glycation of the peritoneum, become very thick. We have a lady in the hospital now who is encapsulating sclerosing peritonitis after her transplantation. And she's just failing to thrive now, not doing very well. The glucose, the dextrose we use for the solution to cause osmosis and removal of excess fluid can actually get absorbed back into the blood, and in diabetic can cause problem with hyperglycemia. Ultimately, the peritoneal membrane may actually fail. We have a test for that. It's called the PET test. You can actually test the integrity and the functionality of the peritoneal membrane, whether it's working or not. Hemodialysis, again, as I said, in center, inpatient, at home, different types of peritoneal dialysis. This is the axis, the Scribner shunt. This is the first shunt in 1960, the first time they gained access to the radial artery and the ulnar vein there to do dialysis. This is the first access. Until now, it's the same idea. Here it is. This is what we do now. Arteriovenous fistula. This is the ideal vascular access. This is a lifeline for a dialysis patient. So don't let your nurses put a blood pressure cuff or anything there. Okay. Complications, emergency hemodialysis indicated for hyperkalemia, pulmonary edema, pericarditis, as I said, cardiac tamponade, uremic encephalopathy, and some people say GI bleeding, severe metabolic acidosis. Okay. This is just the mechanism, the diffusion, the osmosis I described, the ultrafiltration, removal of excess. You see that here. And this is how it works. This is a messenger audio. This is a hemodialysis. This is a hemodialysis filter. This is artificial kidney, the hemodialyzer. I apologize. Sorry. Okay, so this is the actual filter. The kidney. This is how it works. Again, this is my drawing. It's pretty bad. This is the blood coming out of the patient. You see in red there, coming out of that access fistula. It goes into the filter. You see it going up there. And here, the dialysis machine provides the solution, which goes around this blood. The blood is in very small tubes. I have a few here, few filters here. So it goes in there, and then after it gets clean, it gets bathed. It's in a bath there inside it. Around it is a fluid coming from the dialysis machine, the clean fluid. And then all the toxins, the creatinines and all the toxins come out of the blood. And then the clean blood goes back to the patient, as you can see here. Now, you can give any medication here if you want. See that? My drawing is pretty bad. And so, what's the pros of dialysis? It's very efficient, more efficient than peritoneal dialysis, of course. It can then be done acutely as an emergency. We do it all the time. You immediately correct all the electrolyte disorder, the acid-base disorders, the toxins are removed, quick access, very emergent. We actually have dialysis units standby in the emergency room there. Acute complication, of course, hypotension, arrhythmia, cramps, itching, nausea, back pain. These are the commonly described complications of hemodialysis. Okay, what do I mean by conservative management of CKD, ESRD? This is from the KDIGO guidelines, by the way, from 2013. It says refusing dialysis should be an option for informed patients. What does that mean? I mean, I said earlier, you have transplant, you have dialysis, and you have conservative management. That's just symptomatic treatment. If the patient has severe nausea and vomiting, give them something for that. If they're itching, give them some medications for that, okay? But don't do dialysis. They have the right to refuse dialysis, of course. So it should be an option laid out. I tell patients all the time, look, your kidneys are failed. Nothing can be done now. They're less than 10%. So you either do transplant or do dialysis or do nothing, just conservative treatment. Just keep you comfortable. We have to respect patients and family wishes. I mean, I have seen some nephrologists say, okay, you don't want me to do dialysis and your kidney function is 5%, you know, I'm not staying with you. go find another kidney doctor. That's not appropriate. That's not acceptable. Even Kate Deco says that. So we have to respect them. We have to respect the patient and the family wishes. Patients, some patients are very old in their late 80s or early 90s. They are frail. They have multiple comorbidities. What's the point in doing dialysis? Let them just be comfortable in the last few years of their life. Patients who are terminally ill with stage 4 cancer, what are you doing dialysis for them? Death with dignity or life with quality. That's also my belief too, you know. So this is what I want to say about conservative management. Thank you very much, and I think we did very good, Dr. Asma. I think we did